Neurology generally is pursued in general practice and in also in other specialty practices. A boring one. It is so boring, even the computer is not trying to accept some of the few slides that I put it. After listening to an exhilarating talk given by Dr. Rao, I was damn impressed. Now, he showed all the wonderful things and wonderful work that the orthopedist can do at the present time in ordering the walking difficulties, not only in elders, but also in the very young children, to have a good, pleasant life. A fantastic visuals what he showed. I thought I could make use of the walls that he has generated so that I can quickly finish, so that you won't get bored with the talk. I always call an orthopedician as a carpenter and me, neurologist as an electrician. So, after looking and seeing a wonderful carpentry work, I try to present some little bit about the electrical work that what we talked about it. Now, walking difficulty particularly is to the elderly populations. As he said, it is a seminar by itself where you can talk, many hours, particularly to some of the things probably the centers where he has got trained, and the gate laboratory what he has shown. We also got a lab for the locomotions. The amount of the work that has flown in the last about 10 to 12 years in understanding the balance, in understanding the gain, computer simulation and computer technique that are involved in independently analyzing the EMG of different muscles, muscle groups, and trying to identify how they get integrated, so on and so forth has been added. And today, what an enormous amount of material knowledge available to have a very scientific approach in handling the patients who are suffering with the difficulty of balance and walking in particularly. They will do a wonderful job, both the orthopedicians and the rehabilitation specialists, in alleviating some of the walking problems based on the knowledge which have been generated from this. So today we use names which have never been, which are not yet to enter into the textbooks with regards to motor systems are concerned. Now, a lot of new things has come, the interplay of the motor system. They play in maintaining the balance and in the locomotion. I've decided today that I will not go into the details of that because as such, neurology is a boring topic. So I limit and restrict to a level of talking where we can talk basically a glimpse about the walking difficulty, what we see in elderly, and why does it occur, how does it occur, how do we approach it, and what are the common problems that we come across, and some take-home messages. So this is one of the commonest difficulty, but for this walking difficulty, I am sure 80% of the patient would have come to me, 90% patient would have come to Dr. Rao, and certainly 100% of the patient would have come other than pain to Dr. Chandrasekhar. This is one of the difficulties. The proportion increases as the age goes. Can I explain this? Now we use three words before we get into this one because it did a lot on the gait. I just spend a little time on the balance and the locomotion and what controls it, what are the abnormalities. We use the word called an imbalance. Now you see the loss of orientation of the body in the space. Again, a lot of work can be done with regards to the orientation of the body into the space. This orientation is most important in having a balance. Suppose I put in a different geophysical environment, I may not be able to maintain my own balance with intact nervous system, intact musculoskeletal system. Unsteadiness is a difficulty in maintaining an upright position while standing or while walking. Sometimes both are used interchangeably in clinical practice. Disequilibrium is a sensory perception, not being in balance. It can occur even when the patient is lying down. They can be totally imbalanced while they are lying down. Now the balance is a very peculiar phenomenon. What exactly the balance? We really don't know. We balance ourselves. A simple example is when you are in your age of 7 or 8, when you are trying to learn bicycle, you struggle one day, 2 days, 3rd day, 4th or 5th day, suddenly you get a phenomenon called balance. You can balance beautifully on a bicycle, very beautiful, you don't fall. Even now, when you start riding a bicycle, you just cannot fall, purposefully, it's so difficult. So a phenomenon called a balance sets in. What is this balance? In balancing, we have got two important inputs which need to occur. One is a sensory input. In order to get the proprioceptive sensation, which comes from the muscles, joints, and from the skin. And vestibular input, which comes from the deep ear, which goes and mingles in the cerebellum, and it establishes a phenomenon called balance in the human being. The cerebellum, now I purposely made, I will not show any neuroanatomy, neurophysiology, circuits and other things. This cerebellum, with its interaction with the input from the cerebral cortex and the basal ganglia, they interact in brainstem and establishes a phenomena, I use this word, phenomena called balance. We have not understood many aspects of the balance. Now, walking. Having achieved the balance, the walking, which is one of the most complex motor activity. Every day we walk, we run, and walking is our life. And we are all struggling here. We are sitting close something about the walking, and Dr. Rao spends a whole lot of his time in trying to get a better gait to the people, but it is an extremely complex motor activity. And more inputs are coming. All the study data are relevant. Now we are perplexed that how exactly this walking occurs. Where are the generators for this walking in the brain? Still we do not know. It's so complex. But however, putting it in a nutshell, it not been totally true. In the lumbosacral, area from where you get the nerves from the lower limb, the lumbosacral spinal center, plays a very important role in organizing the locomotion. If you look into the walking in human beings is totally different from the walking in other animals. Human being is one of the animals which walk by feet, number one. Number two, another interesting aspect in human being, we are the people who walk with the heel touching the ground first. All other animals, there is a toe which touches first. We are the only animals who walk with an extended limb. All other animals, they will have a slight flexion while walking. Whereas a human being is an extended. This is an evolution which has occurred. An extended muscles, for locomotion that off and on spends less energy, so therefore more effective and more efficient. So therefore this extended bipedal gait, which is extremely peculiar to the human beings. Now these gait centers are the lumbosacral spine center. The final, precision, the dictation, the quantity, how much it should weigh, as you showed, how much should the stay, the stance, the swings, how much should be the cycle. Everything is driven by three important, that is cerebral cortex, basal ganglia, cerebellum, which interact with some of the few nuclei in the brainstem, dictate the lumbosacral spine center how exactly that you should walk depending on the situation, depending on the varied conditions. Now these are again aided by enormous amount of input. Visual, vestibular and proprioceptive input. They modify, they give the information into the cerebral cortex, basal ganglia, and some complex mechanism occurs, and which produces normal walking, which looks so simple to us. It is such a complex which occurs. Any abnormalities in these sections, you get an electrical disturbance producing walking difficulties. The prerequisites for a proper locomotion are, number one, anti-gravity support of the body, because we are the animals who are walking erect. Stepping, which is described about it, maintenance of the equilibrium, the ability to maintain myself perpendicular to my walking space, and a propulsion. These are the four important requisites for the locomotions. The substrates, what are needed to have the normal is the musculoskeletal system, which is delineated so beautifully. Here shown a wonderful picture how the pneumatics can produce. Presence or normalcy of stretch reflex. That is a reflex which occurs in one of the muscle spindles. Spinal reflex. Then the proprioceptive pathways which traverses all along the spinal cord up to the brainstem, cerebellum, cortex and basal ganglia. Cerebellum, intangus of cerebellum, brainstem nuclei, basal ganglia, thalamus and cerebral cortex. The integrity and the complex interactions and the trajectory and the guidance what they give will produce will make you to walk normally. Any disturbances in any one of them produces abnormalities in your locomotion, in your balance. Now if you look at it, when you look at this is a little busy slide, busy looking slide, so it looks extremely complex. Now, as I told you, very important thing that you look for, there are enormous amount of physiological changes which can also influence your gait and locomotion. The neural cell decrease which occurs with the age, conduction velocity which decreases in the nerves, changes in the rates of reflex, deconditioning of the skeletal muscles and the cardiacs, changes in the flexibility of the range of movement, the pain which can occur due to various reasons, can affect neural systems, can affect the cardiovascular system, limbs and joints, and ultimately it affects the movement and the gait. The gait instability, as it increases, more falls, and also the decrease in the balance leads to a decreased perception from visual, vestibular, proprioceptive, that results in further increase in the gait abnormalities. Ultimately, the reactions of the decay that can occur in the neural cells, the other conditioning organ system which occur with the gait produces difficulty in locomotion and also falls. When we are talking about the difficulty in the walking in an elderly population, we should not forget the walking difficulties occur only because of a neural system involvement itself. Varieties of changes that occur in the elders which are normal to the age can produce enormous changes in his walking. Number one, he said, some of the decreased height itself, increased hip flexion, increased flexion of the knee, flattening of the foot arch, itself can produce a change in the posture, center of gravity, and gait can affect it. These are normal changes, but they affect the elderly. The body composition is very important. In the body fat, which increases to become 30% or 15%, alters the metabolism, how the common drugs the elderly people take, that can also affect the gait. Now, several age-related changes which can affect the muscle mass, and type of the muscle fibers which are in the muscles, changes that occur in the water, other content in the tendons and ligament, those produce walking difficulties in the elderly. Now, varieties of changes which normally occur, what are the best food that you are taking, what is the gene which is going to dictate the changes in the cerebral cells, large cell losses in substantial rate. Then you have loss of the anterior horn cells, impaired proprioceptions, and decreased central processing produces significant difficulty in walking. You might have seen what we described as a senile posture. A senile walk is due to the changes that normally occur. So therefore, wherever a person comes with a walking difficulty, you have to assess keeping these things in mind. Other things which will significantly occur is the vision, hearing, and vestibular system, which can deteriorate with the age, can also significantly contribute to their walking difficulties. Now, what does a neurologist, when a patient comes to me with a walking difficulty, what do I do? How do you evaluate? How do you come to some conclusions? I will talk some of the basics of it. When a patient comes with imbalance, all everybody's, whether he has got imbalance with weakness, without weakness. If he has got weakness, then straight away they go into the difficulties of upper motor neuron or lower motor neuron lesions, like a stroke or like anterior horn cell diseases or muscle diseases which produce the weakness. If they don't have, if there is just an imbalance, I have to decide whether it is lateralized to one side or it is symmetric imbalance that the patient has got. If it is a lateralized, I look whether the patient has got nystagmus or no nystagmus. If he has got nystagmus, I look for whether the patient has got weakness or not. If he has got weakness, it will go to the brainstem region. If he has got no weakness, it becomes a cerebral ataxia or peripheral vestibular imbalance. Now, if a person has got a symmetric imbalance, symmetric difficulties, I examine for the sensory system, whether proprioception is involved or not. If proprioception is abnormal, it is a sensory ataxia, peripheral neuropathy, diabetic sensory neuropathy, producing the gait disturbances. If it is normal, if there is a symmetric nystagmus and peripheral ataxia, it is cerebral ataxia. If there is a weakness, it will become as I told you, cerebral hemispheric lesions, if there are no weakness, if the proprioception is normal, if still patient has a difficulty in walk, I consider one of the two common other conditions. One is a frontal apraxia, second is the basal ganglia disorder, notably of the Parkinson disease, which produces gait disturbances. Each one of them we can talk at length, but for the important neurological conditions which produces gait disturbances, cerebrovascular disease, we were considering once upon a time the classical cerebrovascular disease as one event, one episode which occurs and leaves a patient remitting. Today we know that stroke is a progressive condition. Very many small blood vessel changes which occur around the ventricle produce a lot of walking difficulties in elderly population. Second common condition is extracranial syndrome. Commonest, what we see all over the world, is a Parkinson disease. The Parkinson disease has got a peculiarity in a varieties of presentation with the walking difficulties. Many of these elderly people will land up in orthopedics, in other pain clinics. I use a word for a painful Parkinson disease with pain and stiffness in the only predominating sense. Unless you look at exam form, you may totally miss Parkinson disease for many years. Now, another interesting thing that is a front lobe syndromes. Another thing, elderly people around 60-65 come with a short step, slow gait, almost having a gait apraxia, means they cannot decide whether to put a left leg first or the right leg first. We use a word called a gait apraxia. One of the most treatable conditions is normal pressure ventricular. Do you see the brain? You look for a ventricular enlargement, periventricular small hypolucency, normal pressure hydrocephalus. Do a lumbar tap, the pressure comes down, is walking equals. Is another treatable condition. Another condition where you see a significant walking is the dementias. We thought it's much less in our country. With the awareness, we are finding a significant proportion of demented population in elderly. This produces its own effect, particularly certain type of frontotemporal dementia for the locomotion. The next one is spondylotic myopathy. Another condition which really spends about 1 to 1.5 years to make a definitive diagnosis. They go through many pain clinics, orthopedicians, ultimately they end up, when you find a classical upper motor neuron lesion, the lower limb, and some lower motor neuron lesions, we make a spondylotic myopathy. Another common condition in elderly produces significant walking difficulties. Peripheral neuropathies, common as diabetic neuropathies, patient having cancer, paraneoplastic syndrome, vitamin B12 deficiencies, or exposure to toxins, drugs, drug-induced peripheral neuropathy, patients can come with walking difficulties. Chronic subdural hematoma is another condition we should suspect when elderly comes into walking difficulty. For simple reason that there is no classical sign for a chronic subdural hematoma. It is said when I was a student in neurosurgical ward rounds, it is said that if a ward boy suspects a patient has got chronic subdural, you have to rule out chronic subdural. That is the spectrum with which the chronic subdural hematoma presents. If a patient comes with walking difficulty with urinary incontinence about which he is not aware of, suspect chronic subdural hematoma and rule out. It is a remarkable experience once it recovers after a TAVI. The last but not least is the proximal myopathies that can occur in the elderly because of changes in the muscle mass, changes in the metabolism, fiber type changes which can occur. They can also produce a significant walking difficulties. These are some of the common neurological conditions which can produce a walking difficulties. Never forget, a neurological patient at this stage will not come to you with a pure neurological dysfunctions. He will have, in addition to the electrical disturbances, various other system disturbances. Look for partial hypertension. I have seen several cases which has been missed. A patient who comes with walking difficulties while walking collapses down. When you check, he will have a standing blood pressure 60. Sometimes even goes down to 40. A partial hypertension which can occur in the elderly, either because of disease, or because of loss of fluids which can occur unnoticedly, or because of drugs which he is taking. That's another important one that you look for. Carotid sinus hypersensitivity which occurs in elderly, effort simple, arrhythmias and ischemias. Anemia is another interesting common cause which can produce some amount of walking difficulties if it is very severe. Hyponatremia. Elderly population, we have identified some of them do develop a spontaneous hyponatremia, presenting with mild confusion, ataxic gait. They come to you, you take the blood, so serum sodium will be 180, 120. You may find it, not find the cause, treat it, it's very rewarding. Very important thing. Here is a patient who comes to a doctor. Doctor, I feel a lot better since I ran out of those pills that you gave for me. That means lot of elderly patients who are consuming antihistamines, anxiolytics, some antidepressants, some of the antihypertensive drugs, due to some amount of disturbances in their gait, and careful look into their drug intake is most important to identify the cause of the walking difficulty in elderly population. If you take away those offending drugs, they will have a remarkable recovery in their walking difficulties. What is the message today we should take home? The walking difficulty in elderly with a very systematic analysis, rather than dumping it, well regulated, one need not look at it. General medical causes are more important than the pure neurological causes of the gait disturbances in elderly population. Look for subtle neurological signs, which should look like, as I told you, nystagmus, inability to hold the urine, okay, alterations of some sensorium that can occur. Physiological changes from the aging you need to be considered when you evaluate a patient who has got a walking difficulties. Whenever a patient, this is also my experience, like my other colleagues, who comes with pure disbalance with no sign is a great challenge, sometimes extremely difficult to